Vâng. Video jadi itu itu itu
Start ni pun consider ni itu.
Ha?
Start ibu.
Buat.
Start.
Baik.
Kau boleh buat dulu.
Boleh.
Sebab ada tajuk situ kan tu QR dia. Halo.
Ladies and gentlemen, we are about to begin shortly. Please be seated. Ladies and gentlemen, we are about to begin shortly. Please be seated and ensure your mobile phone are switched into silent mode. For attendance, kindly scan the QR code displayed on the screen. QR code is also available on both sides of auditorium walls. Assalamualaikum warahmatullahi wabarakatuh. A very good morning to our honorable guests, Dr. Izamin Idris, Director of HRPZ 2, and all hospital deputy director, head of departments, specialists, medical officer, nurses, and the rest of HRPZ 2 staff. Thank you all for joining our today's CME session. I am Nur Hidayah binti Muhammad Syahid from Unit Therapy Charity will be your MC today. Without further ado, I would like to invite Dr. Isaac bin Abdullah, medical officer from the Department of Cardiothoracic Surgery, to present today's CME with the topic an introduction to off-pump CABG. Please welcome.
Yes.
Yes.
Assalamualaikum and good morning. My name is Aizah bin Abdullah from Cardiothoracic Department of HRPZ2. Today I will be presenting regarding off-pump CABG. what, when, who, and where. So regarding the content for today's presentation, first we will be introduce what is the CABG and the history of myocardial revascularization surgery, the conventionals of CABG and versus the off-pump CABG. What is the cardiopulmonary bypass? What if the off-pump CABG, or we call it short as OPCAP? So why the OPCAP? Who is suitable for the OPCAP, and how is the current practice in HRPZ? So, as we all know, the treatment for the coronary artery disease mainly include medical therapy, the use of antiplatelets, percutaneous coronary intervention that was done by the cardiologist, and the coronary artery bypass that was done by the cardiothoracic team. So CABG was first introduced in the 1960s as the first procedure for direct coronary artery revascularizations, and which then rapidly become one of the most common surgical procedure worldwide, with an overall total now around 20 million operations performed. So a brief pathophysiology regarding CAD. As we all know, it is caused by the plaque within the coronary vessels, which cause narrowed coronary vessels. So patient usually will come to the emergency department with chest pains. So they will be treated either unstable angina, CME, or even MI, and which then will be referred to cardiology for further workup. And they will proceed with usually angiogram. And if not feasible for any PCI, they will refer to us for the coronary artery bypass. So how the coronary artery bypass works? Basically, we took a graft from your internal mammary artery or a saphenous vein graft, and we directly anastomose from your aorta directly to the disease vessels, so that the blood will able to flow back. So brief history regarding myocardial revascularization surgeries. In the earlier days, they targeted for the relief of the symptom, for the relief of the angina. They do not target for the coronary revascularization. So the first surgical for the relief of angina was performed in the 1916s by Thomas Jonesco. He performed a surgical sympathectomy, which patient had a complete relief of angina. And then in the 1930s, they did a surgical thyroidectomy in euthyroid patients who have chest pains as an attempt to decrease the workload of the heart, with some success. And then they eventually shifted to medical induction of the hypothyroidisms. However, in the 1967 and 1968, Rin Favaloro, also known as the father of CABG, had his first CABG with saphenous vein graft, which suddenly become more popular and are currently used in the current practice. And now the vein graft become most frequently performed operations in the whole wide world. So another key features for pre-CABG development is Arthur Weinberg, the first surgeon who do direct implementations of the IMA to the left ventricles. And then in the 1953, the first in-human application of the heart-lung machines was applied. And then from there, the CABG continued to grow. And in the 1973, they first started to use the atrial conduct, and then they start to have a large series of the off-pump CABG. And then from there, the practice of CABG continued to grow. So what is the conventional CABG versus the off-pump CABG? The traditional CABG involves placing the patients on the heart-lung machines and allowing the surgeon to operate on a motionless heart. The heart is arrested using cardioplegia solutions, and heart-lung machine take over the circulatory and the gas exchange functions of the body. However, in the off pump, the heart continues to beat during the procedure. So this is the cardiopulmonary bypass. So as you can see, during the procedure, we usually cannulate the venous systems and the aorta so that the blood will be emptied from the heart and it will circulate into what we call cardiopulmonary bypass machines. And the blood, we will take the blood from the venous systems and to the oxygenator where we oxygenate the blood and warm the blood and then return the blood back to the heart. So the blood will bypass all the heart. The heart will be empty during the CABG so that the surgeon can perform the surgery in a bloodless field. This is the exact bypass machine we use in HRPZ. As you can see, in the on-pump CABG, we have to cannulate the aorta and the venous systems, and also we have to cannulate for the plagia. So what is the cardiopulmonary bypass? It is not a benign intervention and it does not come with risk. As you can see, from the picture I showed earlier, the on-pump CABG involve cannulations of the ascending aorta and the right atrium for the pulmonary bypass. So this atrial cannulation can be associated with bleeding, cannula malposition, and which may cause plug displacement or even dissection, and also may cause interruption in the cerebral perfusions. And then during the procedure, the myocardium is arrested with high potassium solutions, and we have to cross-clamp the aorta to isolate the heart. And then the machines is not a natural system. It's not like our body. Our body, the blood will flow in a pulsatile flow. However, it is not pulsatile flow on the if the blood goes into the machines, and it causes adverse effects on the microcirculations, may cause a risk of microemboli such as microembolic air clots, and the what do they call the machines? They use PVCs, mainly PVCs, and it can cause when the blood get into contact with it, it can cause systemic inflammatory response to the body. So, what is the off-pump CABG? The off-pump CABG is CABG which avoid using cardioplegia and heart-lung machine. So during the procedure, the heart will be continue beating. However, it still requires manipulation of the heart while we have to maintain the hemodynamic stability, and it still requires full sternotomy to reach all the areas of the heart so that we can perform the surgery. However, there is disadvantages and technical limitations for the off-pump CABG. First, the motions of the heart. In the on-pump CABG, we can use the machines and cardioplegia to stop the heart from beating. However, in the off-pump, the heart will continue to beat, and it will be it will be a skilled surgeons to sutures the anastomose. So how do we do to minimize the motions? There is a stabilizer, and we use a mechanical stabilizer to stabilize the heart so that we can minimize the motions of the heart. And then in the on-pump CABG, the coronary, the heart will be empty and there is no coronary flows. However, in the off-pump, the coronary still need the blood flows. So there will be temporary interruptions of the coronary flows during the anastomosis. So how do we counter it? We use luminal shunts or intracoronary shunts during the constructions of anastomosis. And then another issue is usually the pressure drops during the manipulations of the heart during the off-pump CABG. So we maintain it using the inotropic support fluids and translumbert positions. So this is the heart positioner. We use it on the apex of the heart. The main use of this applicator is to gain access to the inferior surface of the heart. As you can see here, this is the apex of the heart. We put the heart positioner with using suction force to able for us to manipulate the heart so that we can anastomose the coronary vessels. This is the posterior part of the heart, and then the inferior surface and the PDA territory. This is the SVG graph that we put on the PDA coronary. The second one is the tissue stabilizer. This one we put on the coronary vessels, between the coronary vessels to stabilize, to immobilize the target coronary vessels, to minimize the movement, the motions of the heart, so that we can anastomose it easier. This is the setup during the off-pump CEBG. Similar here. This is the intralumination that I was talking before, to maintain the perfusions of the coronary blood flow during the anastomosis. I'll show you a bit of video how we do the anastomose during the off-pump CEBG. This is where they prepare the internal mammary artery. And then they start to suture from the distal part. As you can see, the heart will continue to beat during the procedure. And this is the tissue stabilizer to maintain the coronary vessels, the target vessels that we are going to anastomose. It's required a very skilled surgeon to do this during the beating heart. And then once the anastomosis is about to complete, they will remove the intraluminal shunts that was put to prevent the interruption of coronary flows. That's from the anterior part of the heart. For the posterior part, we have to manipulate the heart so that we can gain access to the posterior part, such as the LAD territory, the circumflex territory and the PDA territory. So we use the what do they call heart positioner. As you can see, we use the suction from the heart positioner to maintain the positions of the hearts, and then the tissue stabilizer we still use it to maintain the motions of the heart, and we put intraluminal shunts or intracoronary shunts. And this one we use the SVG graph, the saphenous vein graph, to anastomose the PDA. It's a bit challenging to do the what do they call the anastomosis on the posterior parts, because we need to mobilize the hearts and and we also have limited space for the posterior parts. And similarly, we have to remove the shunts and we tie the knot to complete the anastomosis. So, why off-pump CABG? First, as I told earlier, the on-pump CABG, we have to cross-clamp the aorta. So we put a pressure on the aorta, and the aorta is cannulated. We introduce injury to the aorta, and the atrium is cannulated. However, in off-pump, there is no cross-clamp to the aorta. The heart continues to beat. The aorta is not cannulated at all. The right atrium is not cannulated at all. The both devices that we use both use suction power, and no any cardioplegia is administered during the procedure, and the heart is not rested. The lungs remain inflated, and the body is not exposed to the non-pulsatile flow from the bypass machines, and all the potential complications such as the systemic inflammatory response from the cardiopulmonary bypass can be eliminated. So the benefit of the off-pump, first, reduce the inflammatory response from the bypass machines, reduce renal dysfunction effect from the bypass machine that caused by systemic inflammatory response. So we reduce the risk of renal injury, reduce the incidence of stroke and cognitive problem, lesser coagulopathy and blood transfusion. I forgot to mention that during the bypass procedure, if it's in on-pump CABG, we use heparin untuk cairkan darah patients during the procedure. And another benefits of off-pump is it reduces morbidity and mortality and reduce the length of intensive ICU stay and hospital stay. However, not all patients suitable for the off-pump. We have to select certain patients for the off-pump CABG. So the ideal patient for the beating heart coronary surgery has the following characteristics. First, he or she need to have more than 1.5 mm distal vessel diameter. So you need to have a large coronary vessels, a good ventricular functions, hemodynamic stability, not in heart failure, and we prefer for the anterior wall anastomosis such as LV territory or diagonal artery. So this is the contraindication for the OPCAP. So any patient with hemodynamic instability, poor quality target vessels, such as small target vessels less than 1.5 mm, intramyocardial vessels in the myocardiums, diffusely disease and severe calcified coronary vessels are absolute contraindication for OPCAP. And the relative contraindications are such as patient in congestive heart failure, have critical left main disease, small target vessels, having a recent or acute MI, cardiogenic shocks, and poor ventricular functions, EF less than 35. So how we select patients for the OPCAP? First, we look at the coronary angiogram, CORAS. If the target vessels is less than 1.25, automatically patient is not suitable for the on-pump. Go straight, not suitable for the off-pump. Go straight to the on-pump. And then we look at the target vessels quality. Is it intramyocardials? Is it a diffuse disease? If it's yes, then straight to the on-pump. Not suitable for the off-pump. And we look again to the patient's comorbidity. If his patient has advanced ages, had a recurrent strokes previously, had a history of strokes, had a renal failure, chronic kidney disease, or what do they call disease aorta, such as porcelain aorta. So it's suitable for the off-pump CABG so that we can reduce the risk of the bypass, cardiopulmonary bypass effects to the patients. So what is the 5 years outcome of the off-pump and the on-pump CABGs. Based on this article, they call it coronary trials, a total of 4,000 patients from 90 countries who had coronary artery disease were randomly assigned to undergo off-pump and on-pump CABGs, and they were followed up for 5 years. The result shows no significant differences between the off-pump group and the on-pump group, which is the grade of composite outcome, either death or secondary revascularization, whether by second CABG or PCI, showed no significant differences between the off-pump and on-pump CABG. And the rate of repeat coronary revascularization performed in off-pump is 2.8% versus the on-pump is 2.3% in 5 years outcome. Another article, they call it Ruby trial, 10 years outcome of the off-pump versus on-pump CABG in Veterans Affairs. The 10 years death rates were 34.2% in the off-pump CABG, while the on-pump is 31%. However, the mean time for the first composite event was 4.6 years in the off-pump C group and 5 years in the 4.6 years in the off-pump group and 5 years in the on-pump group. So the composite endpoint was 4.3 month advantage to the on-pump group for the endpoint freedom from death or repeat revascular test. The mean time for the first composite event was 4.3 months advantage on the on-pump group compared to the off-pump group, which free them from death and repeat revascularizations. However, there is no differences between off-pump and on-pump group were seen for the secondary outcome or repeat revascularization. So, how is the current practice in HRPZ? The majority we do in HRPZ is on-pump cases. However, there are certain specific cases we select for the off-pump CABG. And recently, last year, we had a off-pump workshop involving HUSM and HRPZ, and we started to have the first off-pump CABG in HRPZ last year. This is the brief video regarding collaborations with HUSM last year on the off-pump CABG. Here is our surgeon, Mr. Gerard, with Mr. Zudi from USM doing the procedure. And the cardiac NS team. That was the first success of pump CABG in HRPZ, and we will continue to grow further. So the conclusions for the off-pump CABG, off-pump surgery, it offers advantages in the low risk patients, okay, which can decrease cost. So we don't have to use cardioplegia, we don't have to use the pump machines, reduce the length of stays, and reduce the risk of transfusions. And in elderly patients, it also have a benefit which can reduce the risk of strokes, the risk of renal failure, and prolonged respiratory assistance, and perhaps death for the elder patients. While we can see that the on-pump, the cardiopulmonary bypass appears more advantageous in patients who are unstable, who have congestive heart failure, cardiomegaly, and post-MI, and who has difficult target vessels for the anastomos. and difficult, inaccessible locations for the coronary artery. So what's next? So for the cardiothoracic team department, HRPZ, we're planning for the next, we're targeting to do endoscopic vein harvesting. So currently we are using traditional way of harvesting the veins. So we're trying to do a minimal incisions for the endoscopic vein harvesting. We have started the workshops and we are planning to further growth for the endoscopic vein harvesting. And the next step we are planning to do the minimal invasive cardiac surgery for the future, inshallah. Okay, thank you. That's all for me. And then I will proceed to the questions first. I will. So, saya tanya dulu lah. First, we go to easiest questions. What are the two most common grafts used in CABG? The two test. The two most common use graph in CABG. Kalau tak tidur, I first mentioned earlier in my slides. Ada hadiah. Kalau siapa jawab ada hadiah, hadiah kat belakang. Soalan paling senang. The two most common graph used in CABG. Kita tak guna graph lain dah.
Satu saya swing graph, SVG, dengan 5 left is the tamamadi di graph.
Okay, betul. The second questions payah sikit. So I tukarlah two. Just give two benefits of the OCAD. Only two. Tak perlu tiga. Two benefits of OCAD.
Inflammatory response, then bleeding.
Betul lah. Betul. Okay, soalan yang ketiga, soalan paling susah. So, I mentioned earlier, there's a father figure of CABG. So, who is the father figures of the CABG? A. Thomas John Esco. B. Rin Favaloro. C. Arthur Van Berg. D. David Fiske. Tapi semua nama saya mention juga tadi. So, which one is the father figure of CABG? Siapa yang tak jawab? Angkat tangan. Tak dengar?
B. Rin Favaloro.
Betul. Alright, that's all from me. Any questions from the floor? Any questions from the floor? Kalau tak ada, saya serah balik pada MCs. Thank you.
Thank you, Dr. Isaac, for the very good and informative presentation. We now welcome any question or opinions from the audience. If there are no more questions, I would like to invite Dr. Izamin B. Idris, Director of HRPZ2, to deliver the certificate of appreciation to our respected presenter. Please welcome. Thank you, Dr. Izami. With that, we have come to the end of today's CM session. The upcoming CME will be presented by Unit Terapi Cara Kerja with the topic of Atuk nak bawa kereta boleh ke? Boleh tu, tapi for further detail, please join for the upcoming CME. Thank you everyone. Assalamualaikum warahmatullahi wabarakatuh.